In emergency medicine, environmental ocular trauma is entirely governed by the physics of tissue penetration. The exact depth an agent reaches dictates the patient's visual prognosis. Take a common household alkali, like the bleach this child is reaching for. It's a standard domestic cleaner, yet a splash of this often carries a much worse visual prognosis than a splash of concentrated acid. Or consider why a crowd watching an eclipse risks permanent, painless damage to the back of the eye, while a welder working with high-intensity arcs presents with agonizing lesions strictly on the front. These scenarios represent the two distinct environmental pathways that cause acute eye injuries: biochemical insults like acids and alkalis, and electromagnetic insults driven by radiation and lasers. We can resolve these conflicting clinical presentations by mapping the specific pathophysiology of these chemical and spectral agents to their exact anatomical termination points in the eye. Identifying exactly where and why an environmental hazard stops penetrating determines the path of emergency triage and the final outlook for a patient's vision. We begin at the microscopic level of the cornea to analyze the first pathway, biochemical penetration. When an acid with a pH of 4 or lower contacts the eye, hydrogen ions rapidly interact with the tissue proteins of the corneal epithelium. This interaction forces the proteins to denature and crosslink. This diagram of the corneal epithelium demonstrates how that reaction works in the eye's favor. As the acid molecules hit the surface, the denatured proteins coagulate into a hardened barrier. This necrotic shield physically blocks further molecular transit, keeping the damage strictly superficial. There is exactly one clinical exception to this rule: hydrofluoric acid. Its specific chemical structure ignores this protein barrier, achieving rapid and devastating penetration through the cornea. This diagram shows an alkali burn at pH 10 or higher. Hydroxyl groups trigger saponification, dissolving the membrane's lipid layer, destroying the barrier. The alkali pushes freely into the stroma, melting the collagen bundles and proteoglycans that give the cornea its structure. Because of this unchecked lipid dissolution, the clinical timeline for an alkali burn is prolonged. Penetration and tissue degradation continue for days, driven by the eye's own secretion of proteolytic enzymes in response to the injury. If the alkali successfully penetrates into the anterior chamber, the anatomical endpoint is catastrophic. The agent damages the ciliary body and lens, leading directly to secondary glaucoma and cataract formation. An acid's ability to self-limit via protein coagulation makes it structurally less devastating than an alkali's unchecked lipid-dissolving saponification. We can now scale back from the microscopic biochemistry to look at the gross clinical presentation of severe chemical trauma. There is a significant clinical trap in ocular trauma: the assumption that a severely red, highly inflamed eye represents the worst possible injury. The true ophthalmologic emergency following a chemical splash is actually a deceptively clear, painless white eye. This schematic illustrates why. Left, a grade 1 or 2 burn with severe red conjunctival injection. Right, a grade 4 burn with limbal ischemia. This stark white appearance is the complete loss of the microvascular network, causing the limbal stem cells to rapidly die off. The physiological consequence is total failure of the surface tissue.
Without these limbal stem cells, the corneal epithelium absolutely cannot regenerate, guaranteeing chronic surface defects and severe stromal melting over time. Because a severe chemical insult also destroys the corneal nerves, the patient may present with zero pain. The eye looks calm, and the patient feels fine, requiring extremely high clinical suspicion from the examining physician. Vascular blanching is a direct visual readout of total stem cell destruction, instantly shifting the patient's triage status from a topical treatment plan to a severe surgical trajectory. The second pathway of trauma is electromagnetic radiation. Here, penetration isn't chemical, but strictly spectral. Radiation tissue damage is entirely dictated by which specific anatomical structure is capable of absorbing the incoming wavelength. If a tissue absorbs the energy, it suffers the damage. This globe cross-section tracks ultraviolet wavelengths below 400 nanometers. They are almost entirely absorbed by the tear film, corneal epithelium, and lens, never reaching the posterior chamber. Taking this full force causes delayed onset photokeratitis, a painful corneal ulceration appearing after a 12-hour latent period. This mechanism explains why certain environments are highly hazardous. Welders exposed to intense UV arcs without proper shielding routinely suffer from this acute anterior damage, an injury known colloquially as arc eye or welder's flash. The dynamic changes completely when we move up the spectrum to the visible light band from 400 to 780 nanometers and infrared from 780 to 1400 nanometers. Returning to our globe cross-section, we see that because the cornea and lens evolved to be perfectly transparent to visible light, they offer no protection against it. The energy passes straight through and refracts to a high-intensity focal point directly on the macula. This focused energy causes thermal and photochemical burns directly to the retinal pigment epithelium, resulting in solar maculopathy. When imaged with an OCT scan, this injury presents as a distinct punched-out bullseye lesion, confirming the permanent loss of the photoreceptor outer segments. The perfect optical transparency of the anterior segment is precisely the physiological trait that makes the fovea uniquely vulnerable to high-intensity visible light. The entire clinical presentation of acute environmental trauma is a direct, predictable readout of physical penetration depths. This anatomical map illustrates our topographical vulnerabilities. The anterior structures, the cornea and lens, act as the primary shield, taking the damage from UV radiation, strong acids, and surfactants. Deeper inside, the stroma and anterior chamber are uniquely vulnerable to lipid-dissolving alkalis.
And finally, at the very back of the eye, the retina and fovea absorb the full impact of visible light and infrared lasers. This topographical pathophysiology translates directly into first-line emergency management. Because alkalis do not self-limit and continue to saponify tissue over time, the definitive treatment is immediate, continuous irrigation with water or saline for a minimum of 30 minutes. This mechanical flushing must not stop until the clinician verifies a neutral pH deep in the conjunctival fornices using litmus paper. When a clinician understands whether an insult coagulates, saponifies, or transmits through the ocular media, they can accurately anticipate complications like limbal stem cell failure and initiate the exact targeted management needed to save a patient's sight.